Ready to step into the future of home design? Crafted for longevity with durable tempered glass and premium hardware finishes, our shower enclosures ensure your home is ready for whatever the year brings. Out with the dated, in with the modern. Experience a bathroom that's as easy to love as it is to clean. Make this your year of style. Contact Camry Glass today and let's start your transformation.
Never too early, never too late to recharge and hydrate. Get your daily dose the right way. Grab an Oasis, now why wait? Never too early, never too late to recharge and hydrate. Get your daily dose the right way. Grab an Oasis, now why wait? The greatest, the safest, Oasis for sure. Oasis, it's purer than pure.
Enjoy Nice's family of fine foods, including our Jamaican-style patties. This complements Nice's range of premium chicken burger patties, lamb patties, beef hot dog, and our smoked beef and lamb sausages. Also, you can try Nice's halal gummy bears, available at leading supermarkets and at Nice's wholesale outlet. You can also shop for grocery and household items. Nice brand products, 23 Beocle Road, Conopia. Telephone 665-3078 or 665-3079. Nicer is nicer.
Hello, Assalamu alaikum, and a very pleasant good evening to all our viewers and listeners. Welcome to IBN, Doctor in the House, to this special program this evening. We continue to discuss and educate, raise awareness, and advocate for health issues. Please note that these programs do not provide medical advice. If you have any concerns, always reach out to your individual healthcare provider to discuss your specific issues. I am Dr. Amina Khan, specialist obstetrician and gynecologist. I have been practicing medicine for over 25 years, and I'm currently a council member of the Trinidad and Tobago Medical Association. Tonight we have a very important issue, and this topic revolves around high-risk obstetrics. And I have with me tonight, joining me, a very special guest. Her name is Dr. Mary Singh Bola. She is a colleague and a friend from hospital days. She is a consultant gynecologist and obstetrician who completed her undergraduate degree at the Faculty of Medical Sciences in the University of the West Indies, Trinidad. Following this, she did her specialist training in the United Kingdom. Upon returning to Trinidad, she worked as a consultant at the Mount Hope Women's Hospital and also as a lecturer with the University of the West Indies. Assalamu alaikum, Dr. Bola. It's such a pleasure to have you here with me tonight.
Good. Wa alaikum assalam, and it is indeed a pleasure, so thank you for having me.
Of course. So let's dive right into it. When we hear the term pregnancy, we know that it's such a wonderful experience. It's a blessing from God, and we know that for each woman, though, the experience can be different. So what is a high-risk pregnancy?
Good. So I would say any pregnancy in which there is a higher risk of complications either to the mother or the fetus or even to both, that is what we would consider to be a high-risk pregnancy. It should be noted that these complications are things that may arise before, during, or even after a delivery.
And that's really important because, as we know, pregnancy is an entire spectrum that covers, different aspects of care. Before pregnancy, as you said, antenatally, delivery, and afterwards,
Absolutely.
correct? And we see patients, through all, through the entire process.
Yes.
So this can be frightening for some women, though, not so.
Oh, absolutely.
Because there are some pregnancies that can just continue, without any issues, and it's, as we describe it, uncomplicated. So in your experience, and over the many years that you've worked, how would you categorize, or what are some of the risk factors that will make a pregnancy into a high-risk pregnancy?
Yeah. So, there's so many. For simplicity, I think it might be easier to categorize them under maternal conditions, so maternal factors. And age is the one that immediately comes to mind. And by that I mean the extremes of age. So if we see pregnancies in the very young, so teenage pregnancies, less than 17 years, or pregnancies in the older moms, and by older I mean 35 and older, these certainly carry their own unique risks. So for instance, with teenage pregnancies, there's a much higher risk of preterm labor. In the older moms, higher risk of medical conditions, be it diabetes or others, as well as a higher risk of genetic or chromosomal abnormalities. It's interesting. A patient came into the office and she said to me, "Oh, doc, I was told I'm having a geriatric pregnancy," which I found so hilarious. So, ladies, that's not a terminology that we use. We prefer to say advanced maternal age. I think that sounds much nicer.
Oh gosh, I agree with you totally. I mean, geriatric is 80 and above, but from a pregnancy point of view, that is where the issue really comes in.
Yes,
Yes, but I agree with you. Advanced maternal age sounds a lot nicer.
Mm-hmm. And it is something that we are actually seeing more of. So more women are choosing to have and to start their families at older ages. Many reasons, I would say. Changing cultural norms. So whereas before many women were homemakers, you find that women now, they want to achieve a career before starting a family. Another factor that I think that may be impacting on this is whereas women in the past who may have had problems with infertility, with the advent and the increase in access to assisted reproductive technologies, are now able to conceive and become pregnant. So we're certainly seeing women at older ages.
Of course, yes, for sure. Any other, so apart from age being a very critical factor, what else have you seen in our population too?
So things like obesity, this carries a much higher risk of things like diabetes, hypertension, increased risk of thrombosis. That's where women can form clots in their legs and their lungs. Many women may have pre-existing medical conditions. Now, diabetes and hypertension, I would say it's probably the two that we see most often in our practice. And what should be noted is that these conditions carry risk not just to the fetus, but also to the mother. So they have a much higher risk of infections, higher risk of having babies with congenital abnormalities, those with diabetes, that is, a higher risk of having bigger babies and therefore traumatic deliveries, other complications that go with it. Other than diabetes and hypertension, there are so many other medical conditions, although not as common, but equally important. So for instance, things like thyroid disease, things like renal disease, cardiac disease, autoimmune disorders, lupus, rheumatoid arthritis, to name a few.
Sure.
Even women who may have had a previously affected pregnancy or a high-risk complicated pregnancy, such a woman in a subsequent pregnancy would be deemed to have a high-risk one the next time around.
Sure. And even fibroids in pregnancy, right? That is very common in our population.
Incredibly common in our population. Now, not all fibroids necessarily increase the risk. It certainly is an individualized case-by-case basis. And it would depend certainly on the number, the location, the size of the fibroids. But without doubt, when present, fibroids could increase the risk of postpartum hemorrhage, mummies being anemic because of the heavy blood loss that comes with having fibroids.
Right, sure. And then, of course, the condition previously known as polycystic ovary syndrome, which has now been renamed polyendocrine metabolic ovarian syndrome, right? Very common, again, a misnomer, people thinking that it's associated with infertility, but we see many women who do conceive, you know, and that puts them in a slightly higher risk category as well, being pregnant.
Yes.
You know, for risk of
Yes.
diabetes.
Yes,
et
so these
cetera.
patients in particular, the insulin resistance that comes with it, and then that is now compounded by the pregnancy hormones causing more insulin resistance. So they
Right.
certainly have a far higher risk of developing gestational diabetes during their pregnancy.
Yeah. So far, we have listed quite a few. Yeah, and this is just from the maternal or the mom's side.
Yes, sir.
So what about the baby? Because we are dealing with 2 patients simultaneously, in some cases
Yes, sir.
more, right? More than 2? Yes. So from the fetal side,
Yes,
is there
sir.
any category?
So, things like the fetal number, for instance, pregnancies where it's twins, triplets, what we call the higher order pregnancies, certainly carry a far greater risk compared to singleton pregnancies.
Right.
Fetuses with congenital abnormalities, fetuses where there may be an element of intrauterine growth restriction. And this can happen for a variety of reasons, but definitely when present, it increases risk.
Right.
Other than fetal factors, there may be lifestyle, social factors, so things like illicit drug use, alcohol, smoking, sexually transmitted infections, things like syphilis, HIV when present, certainly increases the risk to the fetus.
Yes, and these are important factors, obviously, because the importance of knowing before, and therefore the condition is diagnosed prior to, we can manage them differently
Yes,
to
sir.
maximize the benefit and the outcome, a safe outcome for both mom and the fetus, correct?
Yes, sir. Yeah.
So, are there, for example, if a patient is preterm labor a risk as well? And who are some of the women that can be at risk of preterm labor?
Right. So, for instance, women who may have cervical incompetence, so that's where their cervix is weak, whether that's because of previous surgeries to their cervix or maybe some collagen deficiency. Women who have an increased risk of infections, because infections could certainly weaken the amniotic sac. But certainly these women, women with multiple gestations, much higher risk of preterm delivery as well. In such a patient, if such occurs, it means that that risk in another pregnancy is there as
Right.
well. So there are many risk factors. If it occurs in one pregnancy, can certainly recur in another.
Sure. So, based on what you're saying, though, a high-risk condition or a high-risk pregnancy can occur before a woman becomes pregnant.
Yes.
Or can it develop while she's pregnant? So she is low risk and then it changes?
Oh, absolutely. So as much as we like to identify possible risk factors that could tell us this patient is at a higher risk of developing a complication, there are many instances where seemingly low risk, uncomplicated, healthy women may develop something that is not always anticipated during their pregnancy. So for example, something as simple as where the placenta is located. So a condition called placenta previa or low-lying placenta, when present, it certainly increases the risk of hemorrhage. And this is something that can happen antepartum, so prior to delivery, as well as postpartum after delivery. Some women may have a placental abruption. The placenta separates before time. And not always is it in patients with known risk factors, be it smoking, hypertension, seemingly uncomplicated pregnancies. Some patients may develop placental insufficiency. And again, not always is it because of preeclampsia, sometimes largely unknown. So I think this really emphasizes the importance of adequate antenatal care for all. So
Yes.
that even if a complication were to arise, the earlier it's picked up and addressed, it means the better the outcome we can have for both mother and fetus.
So this is what we consider risk assessment during pregnancy, yes? So as you said, from the first trimester, second, third trimester, you know, adequate monitoring throughout, and always have a high index of suspicion or basically monitoring, because as we said, things can change within, you know, in a day.
Yes.
Or even, you know, later on. So it's really important. You know, we in our system in Trinidad, our healthcare system, we have both public and private. Now, patients who are deemed low risk can be seen at their local health center, correct? If, however, a patient becomes high risk, then it is recommended that they be referred to a tertiary center.
Yes.
So one of our major hospital institutions, or of course, I think even in the health centers now, the specialists can actually go out
Yes.
to the health centers, and they can, you know, patients can be seen and screened and monitored from there,
Yes.
so that they don't necessarily have to attend the major hospitals until the time of delivery. Correct?
Correct.
Similarly, patients who are high risk should actually not be seen, well, should be referred on from their general practitioners to obstetricians like myself and yourself, you know, to be seen and monitored adequately. So what, so we're talking about all these high risk patients. What does it mean for the pregnancy though? Does that mean, so we spoke about monitoring. So
Yes.
what would that include? I assume it would include a whole host of different
Oh,
things.
absolutely. So we are saying that all pregnant women need to be monitored. And the purpose for monitoring is to assess every stage of the pregnancy, both maternal and fetal well-being, because as you quite rightly said, we are looking after two patients and we want safe and healthy outcomes for both. When it comes to the high-risk pregnancies, a little bit different in the sense that they are likely to need closer surveillance. So this might mean more regular antenatal visits. It might mean additional testing. For instance, blood tests, checking glucose levels, genetic screening for the moms of advanced maternal age. It might mean seeing other specialists, and often you find that these patients are managed jointly. So the obstetrician may be the primary lead, but often we may need advice from our colleagues. So endocrine specialists, particularly patients with diabetes, cardiologists, patients with heart disease, sometimes a neonatologist if there's an element of maybe preterm delivery. So a multidisciplinary approach. So a little bit different. They may even need extra monitoring. For instance, if we suspect intrauterine growth restriction, they may need even more scans to assess fetal growth. They may need scans to look at Dopplers, which is the blood flow to the fetus, monitoring of the fetal heart. So their monitoring is really a bit more intense.
It sounds that way, right? And I mean, whereas it may seem like it's a lot, but the whole point and the whole purpose of it, as you said, is close surveillance so that we can achieve a healthy pregnancy and a healthy baby and mom, at the end of it. So, I mean, as you said, could you give me an example then of, like, just summarize what would be some of the additional tests then that the baby would require, for example? Like is an anomaly scan important?
Right, so an anomaly scan is basically an ultrasound in which we screen for any sort of structural abnormalities. And ideally, this is something that should be done in all pregnancies. Of course, there are some women who may have an even higher risk of having a baby with such an abnormality, uncontrolled diabetes being one such example. So all patients ought to have anomaly scans, yes?
Right, sure, great. And I've heard a lot of patients say that the anomaly scan will be able to pick up a Down syndrome baby. Can we clarify that?
Yes. So the answer is no. Ultrasound can help in possibly identifying fetuses that may have a higher risk of having a genetic abnormality. For instance, measuring the nuchal translucency, that's the skin thickness behind the neck. It's not diagnostic, but certainly, if the nuchal translucency is increased, it might suggest that there is a higher risk for this fetus. The absence of a structural abnormality doesn't necessarily mean that there isn't a genetic abnormality.
Sure.
Having said that, the majority of genetic abnormalities, we may see structural problems. So
Okay.
cardiac defects, for instance.
Sure, sure. So that's the difference. The anomaly scan will detect any structural.
Yes.
But of course, there are blood tests, as you said as well, that are used specifically to either screen, and then there's the amniocentesis that we can use to confirm whether there may be a genetic issue or not.
Yes,
And we
sir.
can counsel the patients accordingly based on those results.
Yes.
Yeah.
But technology has evolved so much. So whereas before, amniocentesis, which is a pretty invasive test, having to stick a needle through the abdominal wall to obtain some fluid from around the baby in order to culture cells, quite invasive and not without potential risk. We are now able to do genetic testing simply by taking a blood test on the mother. So we detect free fetal DNA in the mother's bloodstream.
Right, and it's very sensitive.
And in a very early, at a very early stage, sometimes as early as maybe 9-10 weeks into the pregnancy.
Yes, of course. And therefore, well, that's really important because it means instead of waiting later on, you can actually, counsel the patients and whatever necessary, change in management can occur from early on in the pregnancy.
Yes.
So that's very true.
Okay.
So we are talking about pregnancy itself and complications. But what if the patients may have pre-existing medical issues? For example, hypertension, diabetes, or even any autoimmune disorders, thyroid disorders. What is the role for their management prior to pregnancy?
Yes, sir. And I'm happy you brought that up because management of such patients ideally should start even before they become pregnant. So what we refer to as preconceptual care. Preconceptual care is essentially having a consultation with your gynecologist, your family physician, and it's one in which, for instance, a history is taken from the patient, a history to determine whether there are in fact existing medical conditions, previous pregnancy outcomes. We mentioned before that there are many patients who may have medical problems but undiagnosed. For instance, patients with polycystic ovarian syndrome, patients with a very strong family history of diabetes, patients with high BMI, may be diabetic, but just never been tested for such. So I think that preconceptual care is an excellent opportunity to identify such problems. For those with known and existing medical problems like the ones you mentioned, it's an excellent opportunity to optimize that condition, meaning trying to achieve as good control of their condition before becoming pregnant. Simple example with diabetes, having good glycemic control, keeping their sugars as well controlled as possible before becoming pregnant. It therefore allows a healthier outcome, a much decreased risk of congenital abnormalities in the fetus.
And even miscarriages as well.
Absolutely.
Because if the HbA1c is out of control, there's a much higher risk for, the pregnancy miscarrying.
Yes. So I think by identifying this, it means patients are better informed with regards to not just managing, but maybe timing when to become pregnant. Patients who may have other medical problems, heart disease, for example, we know that pregnancy puts an additional strain and increased workload on the heart. So patients with heart disease may sometimes have a deterioration in their cardiac function. And I think this is really an interesting point. We always must inform patients not only what effect their medical condition may have on their pregnancy, but equally important, what effect might the pregnancy have on their condition. So for instance, as I mentioned, those with cardiac disease, there may be a worsening of their cardiac function. So in such a patient, having a proper evaluation, being seen by the cardiologist, possibly having an echocardiogram, because it means that such a patient can make an informed choice whether to embark on a pregnancy or not. There are some patients who may be on certain medications. Common things, for instance, retinoids for acne. Patients may be on methotrexate for treatment of their autoimmune conditions. And these are medications that has a much higher risk of teratogenicity, meaning abnormalities in the fetus. And so they ought to be counseled that you need to be off these medications probably a minimum of 3 months before trying to conceive. Starting them on medications, for instance, simple things like folic acid supplementation. It's known to decrease the risk of spina bifida, neural tube defects, or problems with the brain and the spine.
The spine, of course.
There are many patients who may be on medications, for instance, hypertensive medications, which may not necessarily be the safest for a pregnancy. So switching to something that's safer. So preconceptual care is so important for so many reasons.
Sure, of course. And of course, we can emphasize and re-emphasize on the simple dietary changes and lifestyle modification, right? As you said, you know, there's a scourge of chronic lifestyle diseases, in particular obesity.
Yes.
So of course, these are the opportunities that we can utilize to maximize, you know, the best outcome of pregnancy. And I think maybe a lot of people may take it for granted, but they don't recognize how important it is, so that, you know, it makes your life easier. You know, it optimizes the best outcome for the, you know, for you and your baby.
Certainly, and I think it definitely starts at the primary care level. So this is why programs like this are so important. It means educating, empowering women to make better decisions regarding their health, which will then impact on pregnancy outcomes, and even long-term conditions as well.
Sure.
So patient education, vital.
Yes, of course. I agree with you 100%. So what we will do is we will take a very short break, and when we resume, we will continue our very, you know, eloquent discussion on high-risk obstetrics.
Enter 50 winners have already claimed their shopping sprees at the Sads the Food King and Bright Ideas. From Point Fortin to Mayaro, from Tunapuna to Marabella, families all across Trinidad are winning. Every Saturday, the Super Wins sweepstakes is happening at all 12 Sads the Food King's locations. 50 shopping sprees have been won and 50 more are waiting. So shop, enter, and win weekly.
Never too early, never too late to recharge and hydrate. Get your daily dose the right way. Grab a Oasis now, why wait? Never too early, never too late to recharge and hydrate. Get your daily dose the right way. Grab a Oasis now, why wait? The greatest, the safest, Oasis for sure. Oasis, it's purer than pure.
Chic Leisure Limited, making life easier. Our renowned great tasting vermicelli comes pre-cut in regular and parch, packaged to make preparation simple. Attention all doubles vendors and roti makers, try our high quality pre-sifted bromate free all-purpose and whole wheat flour, low price and conveniently packaged. For wholesale and retail prices, contact Chic Leisure Limited, Warrenville, Conopia. Chic Leisure Limited, quality you can trust.
Welcome back to Doctor in the House with me, Dr. Amina Khan, and my very esteemed guest, Dr. Mary Singh Bhola. We have been discussing the risk factors that can put you into a category of a high-risk pregnancy. Of course, this is not something that we obviously would like women to be in, but it is important since every pregnancy is different. It is one in which we want to maximize and optimize your care to ensure the best outcome for both mom and baby. So continuing our discussion, Dr. Bola, we've discussed the factors, and we have a patient who is high risk in the pregnancy. How do we plan for delivery? So we've been managing her antenatally and optimizing her care. What about delivery planning? Is that also important?
Oh, absolutely. Now, as an obstetrician, those are probably the two most important questions that we always ask ourselves. The timing of delivery, and there's so many factors that would influence this. Now, as we mentioned before, we're looking after two patients, the mother and the fetus. So often the timing of delivery is determined or is dependent on maternal indications, right? So one such example, patients with, say for instance, severe preeclampsia or worsening preeclampsia, so that's where they develop hypertension in their pregnancy, where there is risk to the mother's health, be it liver failure, risk of bleeding, risk of seizures, intracranial bleeding, bleeding into the brain. I mean, this is a condition that can be associated with, risk to the mother's life.
And that's very serious.
That's right.
Exactly.
So if such a condition occurred where there's a risk of impending eclampsia, then immediate delivery becomes necessary. So that would be a reason for maternal reason, regardless of the gestation. And I think this is an important point, that we always put the mother's health first. So as much as we want to have a safe outcome for both, the mother's life always takes precedence. So even if it means delivering at a very preterm gestation in such a case, sometimes that's
necessary.
Is
Sometimes
necessary.
it may become necessary, sure. And you and I both know, we have seen many cases, especially in the public care setting, where even in England, where both of us worked, it's a condition that's, it is scary, actually, literally it is scary, because we have seen both good, not so good outcomes, but as you said, it's very, very important. So if you had to deliver a patient before term, which we categorize as 38 weeks, would there be any special precautions that you can take for the baby, for example?
Oh, yes. So if ever a preterm delivery is anticipated, and this is where we would now look at fetal reasons for delivery. So if ever there is a condition in which the risk of continued in utero existence is thought to exceed the risk of delivery. So in other words, the baby stays in the womb, there's a risk of intrauterine demise or stillbirth. If that risk is deemed so high, then delivery, even at a preterm gestation, may become necessary. In such a case, then we would often administer steroids. These are medications to promote lung development so that there is hopefully less risk of respiratory problems after delivery. It would also mean having to liaise with other specialists, neonatologists in particular, because they're the ones who will be looking after the babies after delivery.
Sure.
It would also mean timing the delivery such that neonatal intensive care support is available if needed. These women often, because of their risk, for instance, with severe preeclampsia, there's a risk of DIC, as we call it, disseminated intravascular coagulopathy. There's a high risk of bleeding. And so an anesthetist input may be very important as well. So again, it highlights the importance of that multidisciplinary approach in managing these patients.
Sure. And you raise some important points because, for example, there are some women whom I've had the privilege of meeting, and quite rightly, some women may ask, so can I have a home birth? So, how would we address in a case like this?
So, even though, yes, I know there are some women who, for one reason or another, they prefer the comfort of their home, may ask this. I always prefer to practice in such a way that in the event a situation arises, it is something that can be dealt with and addressed immediately. And many a time, there are things that happen unexpectedly. So after a perfectly normal, uncomplicated pregnancy, some patients may have postpartum very heavy bleeding. So if delivery happens in a hospital setting, we have immediate access to medications that could arrest bleeding. If it means having blood transfusions, sometimes going to the operating theater to arrest bleeding. Imagine if you were at home with very, very heavy blood loss. So as you can tell, I'm not a fan of home deliveries for that reason. I always prefer to err on the side of caution.
No, I agree with you 100%. I mean, I think we all would agree on that. I mean, there may be some specific scenarios that maybe, you know, patients can possibly consider it, but I think quite the majority of patients, it is better to err on the side of caution. And like you said, in these cases, minutes matter. And, you know, for our, in the public health system, for example, in the tertiary care system, that's why it's important to have access to blood products, you know, being accessible from the blood bank. We already know that there are challenges that we have in our local care setting. So to add on top of that, if you have anything additional, I think would just, you know, increase your risks unnecessarily.
Yes, sir.
So again, emphasizing the point of having, you know, discussions with the neonatologists, with the anesthetists, you know, having to deliver in a tertiary care setting where you have accessibility to all these at your disposal.
Yes.
You know, there are other, you know, issues as well that can crop up. For example, as you said, even bleeding, well, before labor, right? And that's called antepartum hemorrhage,
yes.
Right? You know, is there anything that we can do to prevent that, for example?
Not necessarily. So, for instance, patients who may have a placenta previa or low-lying placenta, often the bleeding is unprovoked. It's spontaneous. It can happen without warning. It can be recurrent. So, as much as we encourage avoiding you know, excessive physical activity, the importance of bed rest, but that doesn't necessarily stop or prevent another episode of bleeding.
Sure, sure. So these women, we kind of, you know, we emphasize a lot on, well, we said the mode of delivery, correct? And we spoke about cesarean section. Do all women who have a high-risk pregnancy, do they all have to have a cesarean section?
Oh, most definitely not.
Oh, that's good to know.
So again, you know, we said it's an individualized case-by-case basis. Very, very often, if we are dealing with complications in which a preterm delivery is anticipated because of, say, intrauterine growth restriction, yes, more often than not, such patients may be delivered by a cesarean section. And the reason for that is a baby who's small may not tolerate the stresses of labor as an appropriately grown term baby. A uterus that's several weeks away from the due date, not ready for labor, it can take very, very long to achieve that. So it depends on the indication. It depends on the stage of the pregnancy, whether a cesarean section may be the preferred method of delivery, but to say that all high-risk pregnancies must be delivered this way, no.
Okay, great. That's important. And just as well, women can go into spontaneous labor, but there is something called induction of labor as well. So can you explain a little bit more about that for the benefit of patients as well? So would some of them would need induction of labor?
So induction, to put it quite simply, means initiating the process of labor. And that can be done for many reasons. Studies have shown pregnancies complicated by diabetes that beyond a certain number of weeks, there's a much higher risk of unexplained stillbirths. And that's actually the main reason why once the pregnancy reaches, as you said, term, beyond 38 weeks, consideration is given to starting off the labor if it hasn't happened spontaneously. There are other reasons as well. Sometimes hypertension. So again, diabetes and hypertension keeps cropping up, but it's because it's so common. So yes, often women, their labor needs to be started because we think there's a higher risk of continued pregnancy going on compared to the baby being delivered at that stage.
Sure. And I mean, the process itself is one that, it's quite common for us to do it. And I mean, the success rate is usually quite good as well. But I mean, again, it depends on how the labor itself, what happens intrapartum as we describe it, meaning during the delivery process. And of course, we optimize pain relief in labor. We have many different options now. Yes, in terms of, well, you can probably elaborate on some of the pain relief in labor.
So now I think adequate counseling of our patients is so important. There are a lot of patients who they think of induction as unnecessary intervention, that things are supposed to happen naturally, so they see this as intervention and may not be keen on that. But certainly if there is an absolute or genuine medical indication, then that ought to be discussed, the reason for recommending an induction. There are different ways, of course, to achieve this, and it depends at that point in time on the cervix, that's the neck of the womb, is it dilated or not. Induction simply means initiating the labor. It's only when labor actually starts would we know how things are going to progress, meaning will the cervix dilate adequately, will the fetus be able to fit into the pelvis, will any fetal distress, meaning the heart rate, drop or not? And these are things that may happen whether labor started spontaneously
or not,
or whether it was induced.
Sure.
So to say that it was because you were induced that these things happen, not necessarily 100% accurate.
Sure, so the two do not go necessarily together. So we've addressed two important myths. And one is high risk means you must have a cesarean section. So we now know that that's not necessarily true. We also know that high risk pregnancy means that the baby will be unhealthy. So we also know that that is not true, because with advancement in medical care and obstetric care, we can safely achieve both healthy mom and a healthy baby. So just this week, I was very grateful and honored to be able to deliver one of my patients safely. And this patient actually she was considered high risk. And in her case, she was advanced maternal age, she had thyroid disease, she also had 2 previous cesarean sections. So combined, risk factors. So, and she was adequately monitored. She had booked very early in her pregnancy. In fact, she had controlled her medical condition before. She booked early, had adequate care throughout, and thank God, had a safe delivery. So this, to me, emphasizes the point that even with one patient, that one patient could have more than one risk factor, not necessarily just one. So, with a combined risk factor as well, requires, as you say, adequate, care and monitoring. And of course, I'm sure you would have had many cases yourself where you've monitored patients, even multiple gestation, twin pregnancy, with advanced maternal age, with probably fibroids in pregnancy. So, again, each patient can have more than one risk factor. While, during our discussion, it's important, I think, for us to advise women out there, are there any warning signs that women or pregnant women should be aware of in terms of, what they should be alert and know what to do in certain circumstances?
Yes, sir. So I think bleeding at any gestation is something that patients should report. Bleeding in the first trimester sometimes may be suggestive of a miscarriage. Bleeding at later stages may be because of a placental abruption or other conditions. So vaginal bleeding at any stage of the pregnancy really is something that ought to be reported.
Sure.
Other than bleeding, reduced fetal movements. So this is sometimes your baby's way of telling you that something isn't quite right. So rather than ignore it, something as simple as maybe monitoring the fetal heart might be a way of getting that reassurance that baby is or is not okay. So fetal movement reduction is something that patients again should
Have to pay attention
pay
to.
attention to. Patients with hypertensive disorders, things like severe headaches or visual disturbances, that might be symptoms that maybe their condition is deteriorating and affecting other parts of their body. So that should also not be ignored.
Sure, sure. And then, of course, abdominal pain, correct? I mean, in terms of, the location of pain, the frequency, intensity, because placental abruption can present with severe abdominal pains.
Yes.
So it's something that women should, or even preterm labor, of course.
Oh, yes.
So it's something that they can't ignore, and it's something, of course, you cannot assess a patient without examining the patient as well.
Sure.
So it is important to have a physical examination.
Yes. I think this is where, having that discussion and counseling our patients is so important because, as you know, women will experience a variety of discomforts. The uterus is enlarging, there's stretching of muscles, stretching of the ligaments, so they will have pain for a variety of reasons. So I think we have to be a little bit careful, when we tell them to report pain. So it's severe,
It's to
pain
differentiate.
that's worsening, pain that's probably accompanied by bleeding. Pain. So
it's to differentiate, yeah. Sure, minor
Differentiate,
pain versus something that is,
Yes.
like warning symptoms, of course. Sure, and that's understood, I have a few questions that probably you could address as well. So can women with diabetes, for example, have healthy babies?
Most certainly, and it all depends on how well their sugar levels are controlled. So with good control, very possible to have a perfectly healthy pregnancy and outcome.
Sure, great. And similarly, women with hypertension, yes, they can have a good outcome, safe, healthy babies as well.
Yes.
Are all high-risk pregnancies delivered early, as in prematurely?
No. So somebody may have a low-lying placenta, may or may not have had episodes of bleeding in their pregnancy. If, however, the bleeding settles, fetus is unaffected, it's always preferable to wait until the baby reaches a term gestation and then delivering. So obviously if bleeding is torrential, fetus is distressed, then yes, earlier delivery is recommended. But if there's no fetal distress, no bleeding or bleeding that settles, then not necessary that delivery has to take place preterm.
Great. And again, I think it emphasizes the point that every pregnancy is an individualized approach.
Oh,
so
certainly.
what may happen for one doesn't necessarily mean it can happen with you or with me. So you did mention, what about future pregnancies? So if a patient has been deemed high risk in this particular pregnancy, does that mean that her subsequent pregnancy will be high risk?
There are certain things, if still present, can certainly put her at a high risk next time around. For instance, patients with medical conditions, so ongoing diabetes, heart disease, sure, that would put her at a higher risk of in another pregnancy. Patients who may have had preterm deliveries, again, there's a high risk of recurrence.
Right.
Somebody may have had a high-risk pregnancy because it was a twin gestation.
Right.
But next time around, it's
Singleton.
So
Sure.
would not necessarily be considered high risk then.
Right, good. So that is also good to know that, each pregnancy can also be different, as you said. So not necessarily all will be high risk. We have patients who, a lot of them want to travel in pregnancy. What would be your advice in terms of traveling in pregnancy? Meaning air travel in particular.
Yes. So again, it comes down to an individualized thing. So if a patient has risk factors like a low-lying placenta, they have active bleeding, then clearly air travel would be advised against. As opposed to somebody with diabetes or previous cesarean section, also considered high risk, but well, good control of their sugars, then, you know, travel prior to a certain number of weeks can be considered. So again, an individualized
basis.
But air travel can be safe in some patients up to a certain number of weeks in their pregnancy.
So we've been speaking about antenatal care and delivery, and we have another important aspect, and that is postpartum care. How do we manage the patients after delivery?
Yes, this is so important because it doesn't end at delivery. So when we look at possible complications, there are things that may happen up until 6 weeks after delivery, which is the postpartum period. For example, women with preeclampsia, eclampsia, or convulsions may happen for the first time after delivery. After delivery, some women may have a risk of secondary postpartum hemorrhage. So the point is, we cannot drop our guard. We need to continue being very, very vigilant, continue close surveillance and monitoring of these patients. So hypertensive patients, we need to continue monitoring and controlling their blood pressures. Patients who may have had an operative delivery, they have a higher risk of thrombosis. So, you know, putting measures in place to decrease that risk. And it may just be something simple as wearing some compression stockings, you know, advising on wound care. But there's another really, really important point that I want to address, and I think it's often overlooked, and that is the mental health of these moms. You know, so women who may have had complicated pregnancies, you can imagine the anxiety, the stress that they would have had to deal with during the pregnancy. Sometimes they're unsure of when delivery may be needed, particularly if it's a preterm delivery, having a baby in a neonatal intensive care, and all the complications that come with prematurity. So it can be stressful. It can be stressful. So these moms are definitely have a much higher risk of postpartum depression. So I think it's something that we need to be aware of.
Sure.
We need to, you know, open those lines of communications, what sorts of support mechanisms they may have.
Of course, very important. And I mean, along with that, you know, because we're focusing on the babies, on the breastfeeding aspect, on the contraception, because we also need that adequately to, you know, to plan for the subsequent pregnancy. The interval planning is also important. So I agree with you 100% with the postpartum care, and their mental health is also essential.
Yes.
Sure, great. So some of the take-home points that, you know, we would have discussed in terms of summarizing everything. High-risk pregnancy, of course, does not mean a negative outcome for that pregnancy. Early prenatal care, in fact, preconceptual care, as you said, is very important, and then going into your pregnancy. It's important to know the warning signs as well for women, and it's also important to know that, you know, it's so important to keep all your antenatal appointments, follow the medical advice, take all medications as prescribed. You know, what would be your final advice to women out there?
So pregnancy can be really an amazing experience, you know, that journey into motherhood. So it is something that if you do embark upon, it is something that you would want to do everything within your power to maximize your chances of having a safe outcome, both for yourself and for your baby. And so it might mean just simple things like lifestyle changes, controlling any medical conditions that you may have, seeing your doctors, keeping all your antenatal clinic appointments. So in other words, doing all the things that you can do.
Sure, that's really, really important. So I would like to thank you very, very much for coming here with us, sharing your expert knowledge, and, you know, just taking the time to be here with us. You know, we have discussed in a nutshell high-risk obstetrics. I know we can go into detail about each one and management for each one, but of course that will take longer than the time that we have allotted to us today. So I would be very happy if you could join us again for future episodes. And it's so important to have these discussions, to start the whole process going and informing patients. So I would like to thank the crew of IBN, the staff, and of course all our viewers and listeners, for without you, our shows would not be possible. I would love for you to join us again for another episode where we would be discussing polyendocrine metabolic ovarian syndrome, formerly known as PCOS. We will be focusing on it being more than a hormonal disorder, the link between that and the skin connection. So thank you very much again, and it was an excellent program tonight and a very enjoyable one as well. Take care. Assalamu alaikum.
Assalamu alaikum. In this, our 20th anniversary of existence, we here at IBN want you to be a part of our family. Call us at 663-4762 or 795-5900. Those numbers again, 795-5900 or 663-4762, and be a part of our advertising campaign. Glorious and available rates to you and your company. So remember, call us here at IBN 663-4762 or 795-5900 and be a part of the IBN family.
Fruitopia, the thing that rocks your lunchtime.